Thank you, and thank you, Dr. Shaw, for this fantastic meeting. So unfortunately, in the U.S., civilian injuries by gunshot wounds are really prevalent in some cities, so I'm going to show you our experience in Atlanta at Grady. Don't have any disclosures. So operative management to the axilosubclavian arteries can be challenged because of its location and the vital structures that surround that artery. Because of this, the access to the subclavian artery can be difficult, time-consuming, and also may require multiple incisions, including sometimes claviculectomies. So multiple reports have shown the benefit of approaching these injuries endovascularly, and this great study by Dr. Zambetti showed that an endovascular approach to these injuries reduced the mortality from 20.5% to 6.2%. And as a matter of fact, in the U.S., the Privet Registry of the last 10 years showed how management of these injuries has increased almost to 100% by means of endovascular techniques. At Grady, in the last 10 years, we've had 153 interventions for axilosubclavian injuries, and we've managed 51 cases endovascularly. And I can tell you the last 60 we managed were part of those 51. And some of the lessons we've learned in the unstable patient, we take the patient straight to the OR and to the hybrid suite. And taking the patient straight to the OR without a CAT stent does not rule out an endovascular option. In the stable patient, that can tolerate going to a CAT scanner, we do it, and then we'll try to put the chest tube in the OR so the hematoma doesn't decompress and gets unstable in the trauma bay. And on the way to the OR, the Foley catheters are really helpful because you can put the catheter and then just tamponade out the bleeding and go to the OR. And once we're in the hybrid room, the decision is what type of access you're going to do. And it depends. So you can go antegrade femoral, retrograde percutaneous, or retrograde open from a brachial axis, or even radial. The benefits of going antegrade is that if you have the unstable patient, you want to get rapid control. Even with a patient without being intubated, you can get balloon control, and then take a deep breath, and they can even put the chest tube or intubate the patient. And you can see the difference in the two. Once we put the balloon, they were able to intubate and put the chest tube. Retrograde access, I think, is great for blunt trauma, especially when the artery is thrombosed, because you can flush the artery. It's sometimes easy to cross this way, but also in difficult arches that you, by going brachial, all those difficulties are forgone. But the reality is that in a lot of these cases, we need to go both ways. So you need to prep the arm and be ready to have brachial and femoral access. Because of these, you have the big pseudoaneurysm, so the wire won't cross. And they need to do a rendezvous technique. So we always have a snare ready, and in 50% of the cases with a pseudo, we ended up snaring and getting through and through access. The next lesson we learn is that stent graft selection and sizing is really important. Remember, all these patients are going to be under-resuscitated, so the CAT scan measurements you get are not accurate. So if it's possible, use intravascular ultrasound. And the question is if between self-expanding or balloon expanding, I think it depends on the location. If you want to be really precise, definitely balloon expandable, and also for proximal lesions. So this patient had a pseudoaneurysm right at the takeoff of the subclavian after a gunshot wound. The patient also had a bovine arch. So here we use a balloon expandable. You can see here there was still a presence of a pseudo, so we were undersized. But the benefit of being balloon expandable after balloon expansion, we were able to seal the pseudo and keep patency to the both carotids. Sometimes you need to be creative. For example, in this injury to the origin of the right subclavian, we did a double barrel and with good success, excluding the aneurysm. In this one, that the location of the injury was at the takeoff of the subclavian, we did like the equivalent to like a SIRA, but in the subclavian. So first a stent on the innominate and then a double barrel. Landing zone is really important for blast injuries to at least get 1.5 centimeters. You can see in this patient that we had an aneurysm really close to the vertebral. We thought that we could nail it, but the mistake we made was by not getting that 1.5 centimeter is that, we're really happy, that then the next day the hemoglobin drop, and you can see a recurrence of the pseudoaneurysm because we didn't have exclusion. What we had to do here was cover the vertebral. We did that, and the patient did okay. Japan is at the forefront on trauma in terms of technology, and they've described the hybrid emergency room system, HERS. I think that's where we're going, and it's just to be able to fix all these injuries in the trauma bay. So you can see here the scanner, and the imaging system is right there, and there's no delay. So hopefully we'll get there soon. So in conclusions, be prepared for, if you want to treat this endovascularly, to have antegrade and retrograde access and have the snare ready, or even open. Do not compromise in landing zone. IVUS is your friend, and also don't forget about the hematoma. By doing an endo doesn't mean that you're not going to need to open, because you're going to have plexus compression and the presence of nerve injury. Thank you.